they've got their camera on up here on this whiteboard.
Okay.
And we are asking everyone to try to,
Okay, then I'm going to let would you like to let the first person in?
please.
Okay, Mr. Ehrenbaum is admitting him right now.
Mr. Ehrenbaum, if you're listening to the meeting on a secondary device, can you please mute it? It says the sound is off again. The audio is not working again. This is back on again. So, Mr. Ehrenbaum, can you hear us okay?
It has been a little off and on, but I can hear you right now.
Okay, great. Well, we can hear you. If you'd like to go ahead and get started, you're welcome to make your remarks.
Sure, thank you. My name is Alan Ehrenbaum. I am with DialCare. DialCare is a virtual health company located in Frisco, Texas, which offers solutions.
We've got some delays.
Sorry. Were you able to hear me or not yet?
Yeah, so he'll need to close down his YouTube or.
If you're watching it on YouTube, can you please?
I'm out of YouTube.
Was that the only feedback you were seeing? Okay. All right. Hopefully we're good to go now.
Okay. So I'm Alan Ehrenbaum. I'm with DialCare, which is a virtual health company located in Frisco, which offers solutions for medical, behavioral health, veterinary, and dental care. DialCare Teledentistry offers members 24/7 virtual access over a phone call or video chat to licensed dentists who can assist with oral health problems or pain, assess oral sores.
I'm so sorry.
I know you all don't like what I'm saying, but I seem to be. I'm getting muted involuntarily. So.
Well, actually, we're hearing you double. So if anything, you're getting double the time. Why don't we're going to try to figure.
I'm sorry, I didn't hear that.
What do you want to do? You can't tell what-
We can do it like a.
I mean, unless it's still not, so we have multiple, I mean, that's.
There's only 2 microphones on. Ours is, so we don't know where this is coming from. So Mr. Ehrenbaum, I'm so sorry to do this, but it's really kind of impossible with the feedback. So we're gonna try our next speaker, and if we're having the same problem, then we'll know. We will get back to you. Thank you so much. Appreciate your consideration. Camera back on. Okay, let's just go to the next speaker then.
Okay.
Just in the for time saving measures.
That's why live is always better. In person.
Why don't we just take people here? Right.
Oh, yeah, I agree.
We're just gonna move on to the people here, and then while we figure out the audio situation.
I think God's telling us.
All right, guys. As we're talking, and it's that's right just now. It was giving feedback for what we just said.
Some of you have the YouTube open.
Streaming and start again, maybe with that.
Potentially,
I'm almost tempted to just turn off the live stream to hear these folks and stuff that the meeting is noticed for live stream.
Open meetings issue with that. We are recording it with the audio.
problem with bringing everybody up to speak is that we're still going to have feedback, and I'm sorry, because now you're all going to have to listen to this twice. But we're contacting our IT director to see if he's at a training, to see if he has any thoughts, because he's really good about how to fix these audio issues when we've had them in the past. So please, thank you. It's you.
Mine is even connected at all.
Oh, really? You should know. Let's get somebody. You want to try virtual again, or?
Yeah, yeah,
Okay.
I think so.
All right, we think we're ready to try again, and we'll let the virtual people go. So we'll give this another try, because he's been waiting.
No. So I think we can do.
I think it's working, because I haven't heard, I don't want to jinx it, but I haven't heard anything.
Okay, I think we got it. I'm gonna ask Mr. Ehrenbaum to unmute and
Okay,
start his video.
please do, thank you. Whew, I don't hear myself again, I know. All right, I'm so sorry about those technical difficulties. We are ready for you, Mr. Ehrenbaum.
Okay, can you hear me?
Yes, sir.
And only one of me.
Only one of you.
Excellent. I don't have a lot to say, so I'll just because I'm not sure what was heard, but so I'll just briefly start over. So I apologize for those of you who have heard this 4 or 5 times already. My name is Alan Ehrenbaum. I'm with DialCare. DialCare is a virtual health company located in Frisco, Texas, which offers solutions for medical, behavioral health, veterinary, and dental care. DialCare Teledentistry offers members 24/7 virtual access over a phone call or video chat to licensed dentists who can assist with the following types of things: oral health problems or pain, assessment of oral sores, lesions, swelling, or infections, advice on how to deal with broken, chipped, sensitive, or misaligned teeth, gum swelling and bleeding, and to provide expert second opinions. DialCare does not offer direct-to-consumer orthodontics or any at-home services, and DialCare does not operate through any physical offices. DialCare Teledentistry is currently operating in all states other than Texas due to concerns about in-person exam requirements. So looking at the proposed rule, we understand and appreciate everyone else's understanding that this rule will allow services like DialCare to operate in Texas without the need to conduct a physical exam of patients receiving the virtual services we provide. Thank you.
All right, thank you so much. We heard you loud and clear and only one time, so we appreciate your participation. All right, we're ready for our next virtual.
Dr. Mitra Darakshan from Align Technology.
Okay.
Requested that they start their video and
Great. Hi, good afternoon. Thank you for joining us. Hi, Dr. Darakishan. Please go ahead and make your comments.
Hello.
Hi, please go ahead.
Hi, can you hear me?
Yes, we can. Please go ahead and give your comments. We're ready for you. Thank you.
Okay, great. Do you guys have a copy of the slides, or can I present my supporting documentation?
Feel free to screen share your documents, but anything you've sent us has been provided to the board.
Okay. Would someone need to give me permission to screen share?
Which I don't think so.
You can just share a screen.
I think you can just share your screen. But also, we can just look at the information in the packets that you sent if that's easier. We have it in front of us.
Okay, sounds good.
Okay.
Thank you for your time. My name is Dr. Mitra Darakshan. I'm here representing Align Technology, and I wanted to address this topic around insufficient doctor-directed care during clear aligner treatment, specifically as a result of the insufficient doctor participation in doing a physical exam, but that physical exam really needs to be done at the beginning of treatment and not at any time, during during 12 months or a year of time in treatment. From the Align, if you look at the Align on your first slide around the doctor-directed care process, you'll actually see that the doctor is so critical in the steps related to orthodontic treatment or specifically to clear aligner treatment, all the way from doing a doctor screening of the patient through to a consultation, physical exam, taking a scan, taking a thorough dental and health history, and then really talking to patients about informed consent. We all know that a lot of times when consumers come and see us as doctors, they don't know all the options in front of them, and they don't know all the pros and cons of treatment, or they're also not always aware of what's going on in their mouths or with their conditions. And that informed consent is such a critical piece of and part of that doctor-patient relationship. When we want to really look at the diagnosis and in-person examination, as we all know, records are so critical. When we look at the option of, okay, we could maybe do a diagnosis or a treatment plan just with a set of photos. Well, we all know, for example, we can't look at tooth mobility. So, in order to do tooth mobility or look at periodontal health or dental health, right, we need to either probe in the mouth, we need to, do our tooth mobility exam. And there's just things that, even as great as a set of photos may be, or a intraoral scan, that can't be done without an in-person physical exam and just looking at the tissue. So So from a in-person exam, it's so critical. And then the reason why it needs to be really prior to starting treatment is, again, if if there's a tooth mobility issue or a periodontal issue, you want to be able to give that patient the right treatment plan. You don't want to start some type of treatment and then 6 months down the line, right? You're like, oh, I missed that, or we didn't know about that, and then be dealing with it. So prior to, again, the criticality of it being prior to treatment is so important. The other piece is around X-rays and their play in the whole record process. We all know that without taking X-rays, it doesn't really complete the record process in the exam process. We don't see what we don't see, right? We all know orthodontics is a complex procedure, and it's moving teeth through bone. And without really looking to see, does a patient have root resorption? Or, what if they're missing some permanent teeth and the treatment plan might be different? Or what if there's an implant and we don't want to move, obviously we don't want to move the implant, and things like this, we can't see either through an intraoral exam or just a set of static records. And therefore that exam is important. And just in the last slide, it was just an example of the case or treatment where it's really how critical the whole record is, plus the exam. This is the same patient with a snapshot of 3 different records. If you just look at an intraoral scan, right, you're going to miss, for example, the gingival recession on the canines because of the way that the architecture of the gingiva, that's not, the real gingiva of the patient that gets displayed in a intraoral exam. If you just look at the intraoral scan and you didn't have the X-rays, you wouldn't have known that there were 2 lower impacted third molars that are horizontally impacted in the way and potentially in the way of treatment, or that need to be addressed either prior to treatment or sometimes during treatment. And the other part, from an orthodontic perspective, if you just kind of look at a photo, you could see that the patient is class 2, but without having, again, records or having seen the patient in person and really looking at their profile and their facial aspect, it's going to impact in how you treatment plan them. So a lot of times in a class 2 case, you have the option of either moving the upper teeth back or bringing the lower jaw or the lower teeth forward. And without having, for example, a cephalometric X-ray or the patient there to take a look at their jaw position and maybe have them posture, and do they have a CRCO shift? Again, something that you can't do without that physical exam. Again, you won't have the picture, which could lead to a misdiagnosis, a mistreatment plan. And again, our viewpoint is that all of this is so critical to be done up front so that patients can have the right quality of care and really the appropriate diagnosis and treatment plan that both the doctor and the patient agree to. So thank you so much for your time, and I appreciate the opportunity to address you.
All right, thank you so much. We appreciate your comments. Have a nice day. Ready for
We don't have anyone else in the waiting room.
Okay, excellent. So the first person I have in the room is Mr. Robert Holden. Hi, good afternoon.
Good afternoon. My name is Robert Holden. I'm here on behalf of Align Technology. You just heard from one of my colleagues, Dr. Mitra Durakshan, and we'll make sure that you have all of her slides for the record as well to review at your convenience, and we appreciate the consideration. We have not been a stranger to the board, so I'll try not to repeat myself. However, we've clearly testified previously in support of the originally proposed standard of care that would have maintained an in-person physical examination. We think that's incredibly important for all the reasons that Dr. Durakshan mentioned in her testimony. And just to again touch on why that's so important to have that oral examination. One is to determine that a patient is a good candidate for orthodontic care and in our treatment clear aligners. Also, to make sure that that treatment plan is a successful treatment plan. And without that oral examination, both of those can result in either bad outcomes or actual harm. And so I know that the board has received testimony from other practitioners and their own experiences in seeing how treatments can go wrong without properly doctor-directed care. We're certainly concerned about that too. So we just wanted to speak in support of that, but also to encourage the board to consider a strong standard of care that requires an oral examination in the case of orthodontia at least. We think that there's certainly treatments other than orthodontia, restorative work and other work that probably would benefit from an oral examination. We would obviously encourage you, as we know you will, to listen to practitioners speak to that. But in sum, I think that as you look to establishing a standard of care, we need to think about if this is going to be the minimum standard applied by practitioner, it needs to be something that will provide provide for the safety and good outcome of treatment. We think that House Bill 2506 specifically provided for the board to do that. And in discussions that were on the public record by the legislature, I think it's clear that they expected you to do that, as I know that you're prepared to do. So we're just encouraging you to do that. So thank you very much for your time today. Be pleased to answer any questions now or in the future.
Mr. Holden, I respect your position, and I know you're looking definitely at the safety of patients, especially orthodontic patients. Do you think the legislative intent of 2056 is to do an in-person exam prior to teledental services?
I think that the standard of care well, let me say this. I think that the intent of the legislature was to allow the board to determine what the standard of care should be. And I think that there are instances in which a physical examination may not be necessary to advance a person's oral health. And a dentist certainly can know when those are. But I think the board needs to provide a standard of care for when that physical examination needs to be made. And I think that they're clearly the practitioners that you're hearing from in many instances think that needs to be an oral examination. It is certainly the position of Align Technology that an in-person examination needs to be made before orthodontic treatment can commence for all the reasons that Dr. Duraction mentioned. And also, frankly, we believe that there should be far more than that. We think that the dentist or orthodontist should be involved with treatment throughout because things can go wrong, unexpected things can come up. And if if we're creating a standard of care where a patient never sees a dentist until after the course of treatment is complete, I don't know how that safety can be maintained for that patient.
So your position is that a reasonable and prudent dentist should or must see the patient prior to orthodontic treatment being initiated?
That is our position, yes, sir.
Should or must?
Must.
Every single instance?
Yes.
Thank you.
Mr. Holden. The next speaker I have is Dr. Benjamin Morgan. Welcome.
Thank you so much, Ms. Nichols. I'm really, really appreciative of the board and allowing us to come multiple times to talk about this. And so I thought I'd introduce myself really briefly and get started. My name is Benjamin Morgan, and I'm a current president of the Texas Academy of Pediatric Dentistry. My private practice is in Rockwall, Texas. I want to talk about, again, changing the Rule 108, the minimum standard of care. And I really do want to say, like, the more we've milled over this in our personal discussions with pediatric dentists, with other specialists, with our lobbyists, with everything we can do, I realize how hard this is for y'all. And I appreciate that you guys have tried to give dentists some autonomy through this. Dentists want to be involved in every aspect of our care, from when the patient checks in to when we deliver the crown. So thank you for trying on that a lot. But the concerns I have about safety have always revolved around the inadequacy of teledentistry as a medium for comprehensive care. And I've talked about that at length and all its shortfall. Today, what I think we need to talk about is, changing that standard of care. As the rule stands now, it references a standard of care that includes initial and annual evaluation. And we actually think we could broaden our care for the kids of Texas, implementing it with those rules currently. I realize that that doesn't necessarily extend to patients that are not of record because of the initial language. And that's hard for the board. They need to expand this medium of care to a bunch of people that aren't in our practice because we have this initial language in there. And what I worry about is when we start to get away from the initial language, then we need clear and concise rules, very clear and concise rules to prevent harm happening to children. And what I mean by that is, say if I get a call on a Sunday and I have a child with a pain and a swelling, I'm going to look at that. I'm going to take pictures via whatever medium we use. I'm going to interpret the data and say, I can give you an antibiotic and advise you pain. Get to my office on Monday. Then I can bring that child in the office and I can see how that child interacts with the people in my staff. I can ask them questions. I can see that they can gag when they take x-rays. I can see that they can hold our hand. I can do all the things that are inherent in treating the whole child, not just his teeth. And I might not send that child to the operating room because I had that chance to figure out how to treat them. If we go through this care level, ambiguity in how we see these kids, then there's potential for many, many, many children to end up in operating room settings based upon 4 pictures and x-rays taken by an assistant. So we're absolutely overdiagnosed the need for invasive anesthesia. These things can be done differently. Another concern I have, if we don't have clear and concise language, dentists that want to monetize children's benefits absolutely have a pathway to do this now without being watched. And I want the board to uphold the safety of these kids' benefits. So if you were to put a dental bus or something in front of a health start center, you could do 250 examinations in one day with 5, hygienists or assistants, and then look at all those exams, and you would be missing lots of things, as we've talked about before. This isn't for comprehensive care. This could become the standard. This could be every repeat every 6 months until these kids' silent decay pops up, and we all have it in our offices. Someone hasn't been to the dentist in 2 years and they have a massive hole and they come to our office with 8 cavities. Well, that stuff's going to get missed. So I want to say we've cemented, in understanding that the board needs to extend teledentistry possibly to people that aren't of record. Then we've submitted some language that we believe is very clear and concise. And I wanted to read it to you. So in subsection 4, we believe it's really necessary to strike the word maintain and replace it with perform. The sentence should read, perform and review a limited physical examination when a reasonable and prudent dentist would do so under the same or similar circumstance. This change is necessary because a dentist does not maintain limited physical examinations. A dentist will maintain the results of a physical examination in the patient's dental record, but he or she performs the actual evaluation. And the next change we recommend is also in subsection 4, and the sentence should read, at a minimum, a limited physical examination must be completed annually. If a dentist is only to review and update a physical examination, the dentist could theoretically never see the patient in person and could instead review and update the physical examination over the phone or internet. So requiring that examination must be completed annually guarantees an actual physical exam will be performed at least yearly, more closely mimicking the current standard of care, and hopefully satisfying the need to include all of, little Texans that we want to look out for. I need to thank y'all again for letting me come and talk to you. And if this devolves into separate standards of care per specialty, I want you to know you are accessible to me any time of day to talk about standards of care for children. But if we're trying to keep it general, this is the best way to do it. And right now I'm here to answer any questions if you have any concerns or anything you want to talk to me about. Sir.
Okay. Quick question, Dr. Morgan. Okay, so you said a lot of things.
Yeah, I did.
So you take different levels of potential issues, with all of this.
Right.
One being supervised neglect.
Right. I'm very concerned about that.
Right. So in other words, you're assuming that if someone does teledentistry, that it's easy to miss diagnoses.
Yes.
You know, not being able to probe, or you're trusting your hygienist or assistant to do that under your license. And well taken, of course. The other issue is really comprehensive versus screening, the purpose of teledentistry. I do agree that you can't do a comprehensive exam correctly, the way the standard of care should be with teledentistry. And at some point, you're probably going to have to look at the patient. But your suggestion about that the patient must be seen for annual exam after the teledentistry. So what if the patient, you don't find anything wrong with the patient via teledentistry, then if the next time the dentist is supposed to do the checkup, they have to see the patient in person at that point. Is that correct?
I'd be very happy with that.
Yeah, so they can't do teledentistry on that same
Repeatedly.
can.
Right.
In other words. Okay, I just want to clarify that.
Be very happy with that. We don't want it to be a repeated thing. It gives people the chance to repeatedly hide problems.
So what if a different dentist does the teledental visit the next year? That would be.
I would have trouble with that because I don't know if that maintains who technically owns the patient.
Right.
And that's why I think this really is sticky. I mean, it needs to be established that after a teledental visit, they visit that same provider in X amount of time. The reason why we're advocating for 1 year is to try to stay away from supervised neglect. We want some safety measures in place. I mean, we all witnessed what happened to orthodontic excessiveness in 2008 to 11, and all the pediatric dentists that graduated in 2012 learned to take off braces from abandoned care. And we know that without a safety measure in place catching this at least annually, we're worried that's going to happen. And I know it's a big jump, but I think it could be there. I really do. And I would, if a different dentist is doing it, I'd prefer it be the same dentist.
Right. So as it stands, you have an issue with the word maintain versus
We do.
perform.
Yes. We want it to be clear and concise. We don't want there any gray. We want to make sure that it's really, really strict that these children will be seen in an office.
Thank you.
Yeah. Working. Okay. Any other members have any questions?
I think we're good.
Okay. I really appreciate you guys.
Thank you very much.
Oh, thanks for all your work. I know it's a beat.
We have next Dr. Larry Tadlock. Welcome.
Thank you for allowing me to speak. I'm Larry Tadlock, and I did submit a written statement. So I'm not going to read that. I will introduce myself a bit. I'm a board certified orthodontist in the state of Texas and practiced for 30 years. Currently, I'm the department head and program director at Texas A&M College of Dentistry, orthodontic department, and I've been part of graduate education for 21 years. As past president of the American Board of Orthodontics, served that board for 9 years, 2011 to 2019, and I still serve that board in a consulting fashion. I also worked with the state as an expert on Medicaid, and I was the lead expert in their lawsuit against the parent company, the oversight company. And I want to talk about just a couple of things that, as I stated in my comments, and others have stated it, an in-person visit prior to the movement of teeth in treatment is critical. It's critical to review the records. And I will mention some things. This week, I called some of my colleagues. And by the way, I'm here representing the American Association of Orthodontists and the Texas Association of Orthodontists and myself. But I called some of my colleagues that are AAO trustees and some of the board members of the American Association of Orthodontists Insurance Company, which is that provides malpractice for about 5,000 orthodontists in the country. And I asked them what are the top reasons for malpractice claims? Top two. Number one is undiagnosed periodontal problems. And number two is root resorption. And it's been that way for almost 10 years. And so I want to talk about those two. Root resorption cannot be diagnosed without the necessary records. You can't see it by doing a virtual interview. You can't see it by looking at photographs of the patient's mouth. And one thing is sure, orthodontic treatment causes root resorption. We have lots of literature to support that. And the amount of root resorption depends on the patient. It can be minimal. It can be certainly, the evidence is about a third of the population, orthodontic patients, has up to 3 millimeters of resorption. And a small percentage, up to 5%, more than that, up to 5 millimeters. In most cases, that root resorption has no consequence. But for patients that have short roots, and specifically, we see a lot of patients in Dallas that are Hispanic. There's a particular group of Hispanics that are often in research world called mestizo. They are more native Indian genome, and they have what's called short root anomaly. Both upper centrals, the classic characteristic is both upper centrals and the premolars have short roots with crown to root ratio of 1:1. What happens for those teeth when root resorption occurs, and it's going to, then those teeth are potentially lost. So with absolute certainty, you know that if you're not doing an inpatient exam and you're starting these patients, it is a 100% guarantee that someone's going to come along and root resorption is going to occur where tooth loss is possible from that. The worst problem, though, again, was periodontal disease. And I put some data in my written comments. The CDC took NHANES study and put out 47.5%, I think, have mild, moderate, or severe periodontal disease, with 38.5% having moderate to severe. Depends on how you classify what periodontal disease is, but that's a significant number. What we know for sure is when there is bone loss and it's untreated, and you start moving teeth around, that bone loss is going to get worse. And the bone loss, the infection becomes much more aggressive, and the bone loss is not reversible. So those two classes of patients are at extreme risk. I want to talk a minute, and I believe you cannot know who those patients are. And so therefore, without an in-person exam, I'm not talking about teledentistry in general. I think it's necessary. But in this particular incident, for treatment where you're moving teeth, you're at risk. The patient is at risk. I want to talk about the term reasonable and prudent and how it relates to the Medicaid issue and why I think it's difficult. The state had a standard for scoring Medicaid patients to see if they qualified for Medicaid payment. And I won't go into that standard, but there were problems with the standard. There were areas of it that were not really understandable. There were other areas where it wasn't specific enough to keep people from wandering and expanding the definition. And so with a number of problems with the standard, coupled with an oversight company that was mismanaged, those two things allowed, so an individual may be reasonably imprudent dentist and attempt to do that and stray from what others believe was the right standard, and therefore were targeted. Others took advantage of the situation and went crazy. And that was the biggest part of the individual dentists that contributed to the Medicaid fraud. The state paid out more in 1 year than the entire country paid in Medicaid reimbursement for orthodontics. And one individual in the state was paid more than the entire state of California paid out that year. So what started out as a desire for a benefit for a part of the population that needs care ended up being crazy abuses. I think this is similar. I think reasonable and prudent people would be able to say what ectopic eruption is. You learned it in school. But when you're scoring a patient for Medicaid, you tend to, maybe you go a little bit this way or you go a little bit that way, and all of a sudden there is no standard. And then it's left to the courts to try to defend. Thank you for everything that you do. I know how hard you work. I know how much time you put in. If you have any questions, please let me know.
Well, I actually just want to make a comment. I'm a pediatric dentist and I practice in Harlingen, Texas, which is more rural. It's a higher indigent population. And I'm very familiar with what you just discussed because I think the practitioners in my area felt the brunt of that whole situation. And so now what has happened, as you know, our Medicaid children are not even typically in most cases able to even qualify for
Correct.
orthodontic care.
Correct.
So unfortunately, the fact that there were a few bad actors, it ended up ruining that for all Texas children when it comes to
Yeah.
orthodontic care.
Not only
So-
that, 75,000+ patients were left in the wind
Mhm.
when all of that was shut down.
So
Yeah.
I want you to know that one of the things for me, and I don't want to speak for Dr. Yu, but I think the board, we are aware that there is the potential for fraud. And it's something that we don't take lightly. It's something that we will try to keep an eye out for. And we are going to continue to do what we can if there are cases brought before us to discipline. But unfortunately, regardless of what happens, there's going to be
Sure.
fraudulent individuals that,
Yeah, I think
and I think the majority of everyone, that when we say reasonable and prudent dentists, we all know that's right. An ethical dentist that's going to do what's right when no one's looking, right? And so it's important to remember there's going to be a few that don't, because we've seen that happen before.
Right.
But I just think I want you to rest assured that we are aware of that, and it's something that affected me, because in my practice now I see patients every day, 20+ patients that need ortho, and I can't get them into someone's hands that can properly treat them. And so,
yeah, the pendulum swung very far the other direction.
Yes.
I wasn't part of that, but
yes.
the from an orthodontic standpoint and not anything else,
Mhm.
when you're moving teeth around and you have that, there are going to be a certain percentage of patients that are going to be harmed and not know it.
Mhm.
So it seems to me that a must statement or a shall statement for an in-person visit before you start would be necessary to prevent that sort of damage. What percentage of population are we talking about? It's not 50%, but it's probably 1 in 4. So that's, I think that's a lot in my view, but I know you have a hard job. I also know all the other factors involved, and I know a lot of people around the country. So
Thank you, Dr. Tadlock. I have a lot of respect for you, for what you do, training the best residents also.
thank you.
But I want to pick your brain. Can I pick your brain real quick? So, obviously as an orthodontist, when a resident graduates in being an ortho specialist, they're beholden to sort of the clinical practice guidelines set forth by the AAO, correct? Okay, and as an orthodontist, a prudent orthodontist would probably see the patient, take radiographs, chart, check the gums, make sure the roots are long,
Right.
check for mobility, all that. And as a periodontist, I respect that especially. But what does the practice guidelines from the AAO say about in person or radiographs or initial exams?
So those clinical practice guidelines came out about the time I graduated from residency. So it's around 88, 89. And so since that time, those practice guidelines have had a number of must statements, including must statements for records and many other things. In 2014, when I was on the ABO board, because we are the standard setting part of the profession, we partnered with the AAO trustees, and we worked on some language that in 2017 was put into the document. It was 2 standard of care statements and some added must statements. Standard of care, well, it was a must statement for records, but it was also restated as this is a standard of care and all of the initial records for comprehensive treatment. If it was limited treatment, we didn't require comprehensive records. So the must statement was for comprehensive. Then we had a must statement for informed consent. Of course, that's in every dental practice. We came back in 2019 and added a 3rd statement, standard of care, for written treatment plan. So those were the 3 standard of care statements, and there were must statements throughout. Somewhere in the process of 2021, the AAO got some bad legal advice, and they removed 22 must statements and 3 standard of care statements. On my way here, the current president of the AAO and I spoke, and I will be on the next committee to put that back in the standard.
So as it stands, because I have the clinical practice guidelines.
There are only about 2 or 3 must statements.
Yeah, because pre-treatment considerations, it says that in-person comprehensive exam should occur.
Correct.
And then diagnosis and treatment plan in person should be made by the dentist. Radiographic imaging may include.
It's worthless. It's worthless.
So you're saying that our board should put in must or shall?
Absolutely. 30 years we had it, and I can pull all those up. 33 years, 32 years we had it. This one.
It just changed.
2021. Every 2 years they review it. I can pull up the 2019.
Well, the reason for the change is that did they feel like they wanted to have the power to? I mean, the orthodontist.
Another reason I called the president, of the AAO, Ken Dillahay is his name, but he had to do a little research. As I understand it, we have a different AAO council now who's in the room. And his predecessor said that organizations, only courts can set the standard of care, organizations cannot. Now, while technically courts set a standard of care in a court case, organizations set standards everywhere. Without them, they can't survive. So what happened is a mistake. I've been put on that committee, so I intend to get that fixed.
Do you feel that every ortho case is irreversible? So in other words, if you're moving 24, 25 and you don't see recession, you don't see bone loss, and physically everything looks the same as far as the indices, and you decide, okay, I'm going to reverse this back to a crowded situation. Is all orthodontics irreversible in your eyes?
It depends on how far you go with the teeth. So if you're pushing them extremely far and then you bring them back, that may not be reversible. It depends on how much time difference between the first and the second. So if you go a couple of weeks and you push them forward and then you bring them back to the exact same crowded position, it probably is reversible. So, I mean, it's rare that I say it's always or never. There are some situations where it could be, but that's not what orthodontics is. I mean, you start it to line the teeth up. We have evidence that long-term, the teeth don't return. You stop retaining it. The teeth don't return back to where they were. They will change and crowd up, but they don't go back to the original malocclusion. So, and for sure, biologically, it's not reversible. I mean, you're killing bone cells that don't just magically return in order to move a tooth. as long as you move the teeth within the alveolus, then you have a healthy situation, and the bone dies in order for the tooth to move, and bone is produced on the backside. So, and you're not violating the alveolus, it's fine.
Reasonable.
Thank you.
Mr. Trey Lawrence, you nodded, so I assumed you were the counsel he was speaking of.
You deducted correctly. So good afternoon, board and staff. Thank you all very much, as always, for the opportunity to speak on these issues. And of course, thanks very much for all of your hard work on that. Yeah, and just for a point of clarification, I am not the legal counsel for the AAO that oversaw those changes. I think Dr. Tadlock summarized the thinking that went into those very well. It was purely perhaps a misguided legal discussion rather than a discussion about the underlying clinical and scientific evidence, which I think firmly from our viewpoint establishes that there are certain components of that initial exam and records that are absolutely a must as opposed to a should. And so I think Dr. Tadlock summarized that very well. So I'm here speaking on behalf of the AAO, the Texas Association of Orthodontists, and our wonderful members that live and practice in the state of Texas. And so certainly many of the folks that have spoken today and are going to speak today are going to address the clinical and the scientific concerns much more capably than I, the lawyer, can. So I want to speak instead maybe to a couple of concerns that the AAO has with legal and procedural issues related around some of the changes that are currently being proposed to Rule 108.7. So I think, first of all, as the most fundamental issue here is we have if we look at the history of this, the existing Rule 108.7 before any of the changes that have been discussed through this process required, not should, but required a limited physical examination at least annually for patients. And so just the fact that we're even discussing taking a step back from that minimum standard of care based on the teledentistry bill, we have concerns with that because for all of the talk about legislative intent behind the teledentistry bill, we don't believe there was anything there that required an alteration to the existing standard of care for all of dental treatment. So, when I read the teledentistry bill, the legislative intent that I see there is, number one, we want to allow teledentistry, and number two, the bill gives this board the authority to adopt rules necessary to ensure patients using teledentistry dental services receive appropriate quality care. So we're concerned that the minimum standard of care is being reduced or stepped back for all dental treatment based on a bill that was addressed specifically just to teledentistry. The second concern that we have is we've heard a lot as we've walked through this process from some of the opponents to taking that existing standard of an in-person limited physical examination and applying that to teledentistry or certain iterations of teledentistry just as it applies to all dental treatment. We've heard concern expressed about, well, that doesn't mash up with the legislative intent of the bill. And so to me, the process of trying to interpret what the legislative intent of the bill is very clear. And actually the Texas Supreme Court made clear, in case there was any doubt on that in 2009, to determine what the legislative intent is, unless the language of the bill is vague and unclear, you look to the actual language of the bill. And so quoting from that Texas Supreme Court case in 2009, where the text of a statute is clear, text is determinative of that intent. When possible, we discern legislative intent from the plain meaning of the words chosen. This general rule applies unless enforcing the plain language of the statute as written would produce absurd results. So again, when I look at that bill, we've got an authorization for teledentistry, and then we've got an authorization for this board to prescribe rules that, and I don't want to misquote the language here, to prescribe rules that ensure that patients using teledentistry dental services receive appropriate quality care. So there to me is the legislative intent. The tea reading that I've heard going on from some of the tea leaf reading that I've heard going on from some of the opponents of this in-person requirement, saying, well, that doesn't match up with the legislative intent that the sponsors of the bill intended, or that others who voted on this bill. Again, I want to bring us back to the language of the statute itself, where the Texas Supreme Court told us that we need to look, and that says you look to the text of the statute there. And there I see clear authorization for this board, being the experts in this area, to determine what is the appropriate standard of care for this treatment, and then to prescribe it accordingly. And so that's where I think you all can then rely on all of the clear expression we've heard from the clinical experts to determine what that standard of care is and put it in place as a part of these rules. And then finally, the last concern that we have, this was already hit on by the pediatric dentist specifically, but we have some concern about the vagueness. You know, we feel, number one, that the current physical exam requirements in 1087 shouldn't be taken out in the first place, but then pivoting over to the proposed language that we've seen, we share the concern that the should, as opposed to the must or shall, interjects a level of vagueness that's going to make it difficult for this board to then carry out the enforcement responsibilities on the back end. And the reason for that is because, you know, again, as much as we want to talk about, you know, whatever percentage of reasonable practitioners understand what reasonable and prudent care is, there are, as we've heard mentioned, there are those that are looking to monetize some aspects of treatment, and they're going to look for loopholes, and they're going to look for places to take advantage of vague language. And in this particular instance, as this subject has been considered around the country, they've in fact done that, and they have told dental boards that where the language was too vague, that the dental board could not act to carry out a certain enforcement action, and if they did, they were going to be sued. And so that's why we feel very strongly that with the authorization in the bill for this board to exercise its clinical discretion and put rules in place, those rules need to be specific enough to prevent those kind of legal challenges on the back end of enforcement. Because those who are going to look to push the boundaries of the rules are then going to try to exploit vagueness in the rule when the enforcement action comes and say, you can't undertake that enforcement action against us because the bill doesn't allow that. So finally, you know, we've heard a lot of voices in support overall for this in-person requirement. And to me, that seems like a overwhelming consensus of the clinical agreement on the importance of that in-person limited exam, especially in particular, as we've heard, with orthodontic treatment. I know we're going to hear from some who don't believe that that is necessary. They're going to say that the minimum standard of care doesn't require that. It's not clinically necessary, or whatever the other arguments are. And just kind of in preparation for hearing those arguments, I just want to make sure that everybody's clear on where that argument's coming from. And in particular, I just recently discovered the words of one of their own allies, one of the organizations that's pushing that opinion that I think say it best. TechNet is an organization that's been speaking out on this issue in a number of other forums, and the AAO, we're hearing arguments from them at this moment in some other states that are considering this issue. And in particular, two of the largest direct-to-consumer or mail-order orthodontic companies are members of that organization. And I was recently reviewing their website and ran across a phrase that I think probably describes it even better than I could have. I read on their website that they use the phrase self-service healthcare to describe the teledentistry and the telehealth that they're pushing for. So to me, when we've heard all of these clinical concerns from a broad consensus of practitioners in this area, and then I come across that the organizations and their association that are saying, no, you shouldn't do this, you shouldn't include this requirement, you don't need in-person, that they're advocating for self-service healthcare. I mean, I hope that gives you all the same kind of chills down the spine that it does me, the lawyer, when I read that. I don't think anybody in here, I think everyone in here that practices understands that there are certain components of healthcare, specifically dentistry, and most specifically orthodontic care, that cannot be self-service. And that's why some form of that in-person requirement is necessary. So, you know, just to conclude, when we get to what specific language is the AAO proposing, certainly some more specific clarification of a requirement, the must or the shall, as opposed to the should, that's already been discussed, we would strongly prefer to see in the rule. And then secondly, again, you know, I've heard various wordings. I think Align or possibly proposed a different slightly different wording than we did, but the AAO suggestion was to require an in-person exam before irreversible dental treatment. We're not wedded to those words exactly. I think the concept, all of the stakeholders who are saying something like that are saying the same thing. There's certain types of dental treatment that you can't go back on, whether it's the treatment itself or the harm, I think is the bigger, Dr. Tadlock was talking a second ago about irreversible, and certainly the root resorption or some of the other possible harms are not reversible. You're not going to grow those tooth roots back if you lose them because you didn't see the patient in person. And so whatever the specific language is, those kinds of treatment, this is not the emergency triage situations or the oral health education, other areas of teledentistry that clearly don't need that in-person exam before you start seeing the patient, but there are certain treatments that do, and those are the ones that we feel very strongly about and are here to speak about today.
Thank you.
Thank you all.
Our next speaker is Dr. Clark Colville.
Good afternoon. All right. Well, I very much appreciate the opportunity to come before you today to discuss this. And I was even more encouraged when I hear you start out the meeting where I heard the mention of patient safety 3 times from both of the doctors and what the purpose of the state board is, because I think really what this comes down to is keeping that first and foremost. I've given a written testimony, and you'll be able to read that for things that are the things that I would like to clearly state. I'm going to try my hardest not to read through this again, but at the same time, I kind of want to be thorough about some of the things that I want to say, and a couple of things may require a little technical reading so that I get it right. But I am Dr. Clark Colville. I'm a private practice orthodontist practice in Seguin, Texas, about an hour from here. Been a board certified orthodontist practicing for 29 years. And on top of that, I have 23 years experience treating patients with clear aligners, past president of the Southwest Society of Orthodontists, Texas Association of Orthodontists. And I'm been an associate clinical professor at the University of Texas graduate orthodontic program, where my primary responsibility is training the residents to use clear aligner therapy. I have concerns over the proposed rule, and I want to start out by saying, yes, I do believe there's a place for teledentistry to be implemented in the state of Texas. So I'm not speaking against having teledentistry in the state of Texas. I believe it has an appropriate place and is needed. Where I have concerns, like many of my colleagues, is where we're going to talk about orthodontic treatment. And for orthodontic treatment, patients of record who have a physical evaluation of the hard and soft tissues, the necessary diagnostic records, a written diagnosis and treatment plan. After discussing and consenting to the proposed treatment, understanding the risks and limitations of that treatment, there are some places that they can benefit from teledentistry. So I'm not saying that teledentistry isn't appropriate for all of orthodontic treatment. There probably are situations where it's appropriate. I could list some of those, but I will just tell you it's not a blanket statement that teledentistry isn't for orthodontics. I just think we really need to think about appropriately where that is. I think this more directly points out kind of what was said today. I think the rule as proposed is a little bit vague and could use some clarification so that we can get some of those things ironed out. Initiating orthodontic treatment without that physical evaluation combined with necessary high quality diagnostic records can result in irreversible damage to the teeth and the periodontium. I think that's been spoken to. I would like to, I know you've heard testimony before on these type of things, but I will just tell you as a practicing orthodontist, we see impacted teeth, supernumerary teeth, ankylosed teeth, deep periodontal pockets, abscessed teeth with draining fistulas, teeth with hypermobility. This is a daily occurrence for us. These are all the things that, as I say in my report, a set of 5 poor intraoral photos taken from an iPhone and a very poorly done self-administered impression of some sort is not going to capture these things. And so that leads to errors. It leads to errors in diagnosis. It leads to errors in treatment planning. Ultimately, can lead to damage to the patients. The proposed teledentistry rules have struck the requirement to perform an initial medical history and perform a limited physical evaluation. I think the language that was proposed is very vague and states the dentist shall maintain and review a limited physical evaluation when a reasonable and prudent dentist would do so under similar circumstances. Myself, I cannot imagine, a circumstance where a reasonable and prudent dentist would think that it is appropriate to initiate a clinical procedure that could cause irreversible damage without adequately assessing the hard and soft tissues in person. So it's just, that's the nature of orthodontic treatment. That's what I consider reasonable and prudent. However, we, in the rules as it's proposed, we have lowered the standard of care for all of dentistry. And by doing that, we're going to have bad actors that are going to practice at what I say is the lowest level of competence for the profession, and that can create harm. The other argument that I heard and was mentioned, I think Dr. Yu said something that caught my ear, and I put that in my argument as I've heard discussion that this will increase access to care by allowing this type of teledentistry for orthodontics will increase access to care. I have two specific responses to that. First, eliminating the requirement for a limited physical evaluation prior to initiating procedures that could cause irreversible damage will only increase the access to substandard care. Second, and this is personal for me because I practice in this type of community, I think the people that are most harmed by lowering the standards of care are those people who have limited access to care. They have fewer opportunities to seek dental professionals because there's fewer professionals available for them. They're typically less educated. And so when you lower the standards overall, those are the people that are going to be the most harmed because they just don't have as much access to get the information on what appropriate treatment is. And unfortunately, those providers that want to provide just the bare minimum standards of care know this and take advantage of it. And so this comes directly to patient safety. I think we need to maintain as high a level of minimum standards of care as we can. Access to care is an issue about the quantity of dentists serving the area, and it should not be about the quality of care being provided. The state should not compromise in this critical area and should advocate for and protect those with limited access to care and specifically protect them from substandard care. So as I mentioned, I am a dentist that practices in a rural community, less than 30,000 people, where the per capita income is less than half of what is for the average in the state. I have witnessed firsthand the irreparable damage that has been done by performing, do-it-yourself orthodontic treatment. I have had people show up with aligners not fitting and asking me to see why when there's calculus bridges on the teeth. There's no chance for those teeth to move. And even more extreme circumstances, I've seen people come in who were told by their physician that they probably should widen their arch so that they could breathe better. And these people have, not understanding that this could not be done by an online platform, come in and tell me, well, I was told that yeah, this would be very appropriate for me to do that. And this is a patient who needed significant medical attention. And, the orthodontic treatment that would have gone along with that would have been very complicated. And the idea that they were, sold some plastic online and said, yes, this is perfect for you. Those are the things that can be avoided by having an initial in-person examination, not some examination performed at some point during the year. So again, I think we can come up with some wording that can address having an exam for orthodontic movement prior to treatment. The common theme with the patients that I see that I feel have been taken advantage of is most of them were led to believe that the care that they were getting was appropriate for them. They were misled and uninformed. And I think that's sad. And again, it comes back to patient safety. My final concern with proposed rules pertains to the inconsistency that the changes create within the Dental Practice Act. Under 108.16, Number 2 states the following: a dental health professional providing a dental health care service or procedure as a teledentistry service. Item C, must maintain complete and accurate dental records as set out in 108.8. So if you go look at 108.8 and you look at it closely, it generally states that a Texas dental licensee practicing dentistry in the state of Texas shall maintain and keep adequate dental records for each dental patient for the protection of the patient and the dentist. So what does compromise adequate dental records? Item C states, further, records must include documentation of the following when the services are rendered: written review of medical history and limited physical evaluation. And further down, documentation of the findings of a tactile and visual examination of the soft and hard tissues of the oral cavity. So as the current rule is written, the requirements for record keeping cannot be met. This will need to be addressed in further detail. So my request would be that 108.16 teledentistry rules be further modified to define the scope of services appropriate for teledentistry, and the changes made to 108.7 regarding the minimum standard of care, not 108.8, not be amended as proposed. I think that would maintain the highest standards of care to protect the public. Thank you.
Dr. Colville, you do realize that this teledentistry bill, to me, it can be used for good. And
Absolutely.
it's, and what I mean by access to care, I mean, the patients that cannot be seen in nursing homes and the handicapped, the physically handicapped that can't make it in. Children, in rural environments where they normally can't get screened by dentists and they can't make it to them. So, I think this can be for good. And I realize that, everyone, most here are orthodontists, and they do have, concerns about this. And unfortunately, we don't have a carve out for orthodontic care in this bill. I mean, we don't want to penalize the ability of teledentistry to help people either.
I agree. You have a very tough task. I don't minimize the task before you, but and I prefaced all of my comments starting out by saying, yes, there is a place for teledentistry, and it can serve a lot of good broadly in a lot of areas.
But your points are well taken, so I really appreciate it.
All right.
Thank you.
Thanks for having us.
Our next speaker is Dr. Jeff Solzer. Welcome.
Hello, everyone. Thank you for allowing me to speak. My name is Dr. Jeffrey Solitzer. I'm Chief Clinical Officer at Smile Direct Club. I'm a general dentist for 37 years, and I've been the Chief Clinical Officer for 5 years at Smile Direct Club. I'm here to represent Smile Direct Club and most importantly, our Texas licensed orthodontists and general dentists who affiliate with Smile Direct Club to provide a teledentistry platform to treat patients for mild to moderate crowding and spacing on clear aligners. I have a couple of comments to make. First, I'm just not real clear. We're not clear as to what's meant in the statute regarding the fraud and abuse scenarios. And in essence, from a clinical perspective, what does that mean? I spent 23 years running dental insurance companies in my career, and typically fraud and abuse is referenced to billing and insurance and doesn't have a clinical connotation to it. So I just wanted to get some clarification around that. I'm just kind of confused by that. We are. And then also, how would even teledentistry be any different than the traditional setting regarding fraud and abuse? It shouldn't be any different. So I wanted to make that statement. We understand the revisions in the language in 108.8 regarding records keeping. But I want to speak a little bit about 108.7 regarding the standards of care, because the way we see it, we should clarify or add a statement such as, quote, as appropriate, unquote, at the end of section 2. Otherwise, it seems like the records keeping section is dictating clinical activities. Now, it's supposed to be the other way around, right? In essence, this is the tail wagging the dog. And it just doesn't make any sense because there'll be services, certain services that don't require x-rays. They may not require prescriptions for medications, whatever those services may be, or even a tactile exam at that moment. So to have a statement in the records keeping that would create unnecessary clinical services just doesn't make any sense. Talking about maybe fraud and abuse, but waste, fraud and abuse, that even adds to waste. It just doesn't make any sense. So there has to be a clinical advantage gained from diagnosis, treatment planning to perform those services, and it shouldn't be dictated by a records keeping rule. Also, I just want to comment that the AAO appreciate their attendance here today, but they don't set standard of care. I mean, they can make recommendations for their membership. They're nothing more than a trade organization. They're not a regulatory body. Appreciate their comments and their insight, but there are orthodontists in Texas that are not members of the AAO. They don't need to follow those recommendations that they're making. And most importantly, there are general dentists who are allowed to perform orthodontics, and they wouldn't be bound by this either. I don't even know if members of the AAO are bound by these supposed standards, but they're not in a position to create standards of care because, as the rule correctly states, the profession sets the standard of care, the actual prudent provider, and not trade organizations. So I'll just leave it at that. I just also want to comment that at Smile Direct Club, I can't speak to others, but we're not promoting self-service. Our affiliated Texas licensed orthodontists and general dentists prescribe, manage, and direct the care from the very beginning to the very end. We are opposed to any self-service. We're opposed to mail order or whatever that comment means. And we're certainly opposed to do it yourself. You know, the industrious 14-year-old who might go in and print aligners because they saw something on, on YouTube or whatever and thought it was kind of cool to do it. So we're against all those things. We don't believe in that. We believe in doctor-directed, doctor-prescribed care. We'll clarify all these comments in our written statement that we'll submit, but I do want to thank you all for spending time and hearing me out and who I represent. Yes.
Dr. Seltzer, thanks for coming here. In terms of the board, I realize that we enforce, we enforce and we make sure that practitioners are following the standard of care. And in essence, yes, we interpret the standard of care, but at the same time, trade organizations look at their literature and look at the profession and give clinical guidelines that we go off of. So in a way, we kind of look at holistically, what is the acceptable standard of care. And so you're right that, trade organizations should never set the standard of care, but I think there's enough high level research that they base their recommendations on that we look at also. Just like the reason why we, in our rules, we don't say that you have to have isolation for root canals, but we enforce that, so that's kind of a widely accepted standard of care. And just like, if there's evidence of periodontal disease, you should probe and do radiographs, for instance. So I think your points are well taken.
Sure, and I respect that. And I think we should listen to the AAO's recommendations. I think we should listen to everyone's recommendations and then look at the professional community who sets the standard, and you folks would then regulate that, which makes sense. So I think we're in agreement, I think. So thank you.
Thank you.
Mr. David Mintz, you are our next and last in-person speaker, unless anybody else would like to sign in. And then we have one virtual speaker after you, and then that's all we have signed up so far.
Good afternoon. My name is David Mintz. I'm here today representing the Texas Academy of General Dentistry. I want to echo a lot of the comments you've heard today, and also what I understand comments submitted by the Texas Dental Association. Texas Academy of General Dentistry supports amending the proposed language in section 108.74 to clarify that there should be a limited in-person exam done annually. Specifically, we would suggest the following language by amending 108.7.4. Say, perform a limited in-person physical exam when a reasonable and prudent dentist would do so under the same or similar circumstances. At a minimum, a limited in-person physical examination shall be performed annually. I do have a letter from Dr. Brooke Elmore, president of our organization, reiterating that. Thank you.
Anybody else in person would like to speak? No? Okay. You want to, is you ready?
Yes.
Okay, excellent. One more virtual speaker and then that's all we have signed up.
In a minute, I ask them to start their video.
Okay, great. Hi, good afternoon, Dr. Adcox.
Hi,
Hi, we can hear you. Please go ahead.
great. Well, thank you for your time. Again, my name is Dr. Josh Adcox. I'm an orthodontist here in Harker Heights, Texas, and I'm a partner with Smile Doctors. And Greg Goggins has given some documents from members of our group of orthodontists who have had challenges with some of these direct-to-consumer style treatments, modalities of some problems with how it's going. Now, my background is this. So Smile Doctors, I believe in remote care, or we call it teledentistry, I guess. And I believe that it's an important part of our profession. And it is even better when driven with AI or artificial intelligence style treatment modalities. However, it's critical. Hey, I got a little visitor. I'm so sorry. It's critical. This is my daughter, Coco. Can you say hi? Hi. It's critical that we have a proper diagnosis and treatment plan. And for me in my office, hi, I'm so sorry, you guys. Yeah, for me, it's really critical that we have this. Hey, go see your brother. That we have this with an X-ray. Okay, so for me to be able to have a remote style treatment, I need to have a proper diagnosis, and I can't personally do that. And it's kind of been the standard of care from my learnings that we do that with an X-ray and an exam. So and not being able to do that within a year, I don't feel comfortable treating a case unless I can at least have a diagnosis from a dentist that we're free of periodontal disease or any sort of infection that we can't see in a photograph. Believe me, I do teledentistry every day, and I treat a lot of my patients this way. She's so fun. She's my favorite. But only after we've given a good diagnosis to start, and then the AI and the teledentistry as we go week by week with how we have designed our processes for remote care, we're confident that we're continuing to have the proper standard of care for our patients. I personally haven't had a patient come to me that has had some of these issues, but I've had colleagues that have, and it's concerning for them, and it's concerning for our group in general. And so I happen to have the opportunity to, visit with you today to represent Dr. Goggins, since he wasn't able to. And in my opinion, day to day in my office, that's my professional opinion, that we should be able to have an exam and get that diagnosis set properly, and have one doctor assigned to a patient to follow up with it from there. I know I'm kind of rambling now. I'm kind of distracted. So if you have any questions for me.
Thank you.
Thank you, Dr. Adcox.
You're welcome.
Mama.
Anybody else right Dan? Okay. All right. Thank you all so much for your time. Did people go? Did your people go? Good. everybody's good?
Thank you.
All right, thank you very much.
Time now is 2:35. Meeting is adjourned.